Um, Today we have a really special treat for you. Our dynamic duo of Robert Deiss and Courtney Thompson are going to be doing a combined presentation about a lot of the work they've been doing for the past 2 years. I think they'll talk about that. And what Courtney's been doing for longer than that as our transitions of care coordinator. But I'm going to introduce each of them and then pass it along to them. I think people have heard Dr. Robert Deiss speak before, but just so those who don't know him, he joined the Owen Clinic as an attending physician in April of 2020. After a long and winding journey home. He received his MD at UC San Diego and then trained in internal medicine and infectious diseases at Harbor UCLA Medical Center in LA. He previously worked at the Naval Medical Center, San Diego, and Doctors Without Borders in Mozambique. I didn't want to butcher the French version. In his current role at the Owen Clinic, he is part of the Transitions of Care program, and he'll be talking about some of that experience. Now, Courtney Thompson is a board certified family nurse practitioner with UCSD Owen Clinic and certified as an HIV specialist through the AHIM. I'm sorry that I didn't do the whole acronym out loud. Courtney started her career as a registered nurse in 2008 and advanced her education, graduating from UC San Diego's Doctor of Nursing Practice, Family Nurse Practitioner program in 2014. I asked for fun facts from both of them. Maybe Robert will provide his himself, but Courtney shares that while in high school on the dance line, she performed at the halftime show at Hawaii's Hula Bowl. That is very cool. So Robert, you'll have to figure out something when you present, but I'm going to pass it on to the two of you. I'll keep an eye on the chat, but I think either it may be easier for you two to monitor each other and interrupt, but I'll keep an eye on it as well.
I can't compete with a hula bowl.
No, I didn't.
Yeah. So yeah, I'll just pass. I put my fun facts on my CV just because if anyone reads that far, they'll learn a little bit more about me. So,
do you want to put up your slides?
Sure, thank you. So yeah, Courtney and I it's a joint presentation. Everyone can see the PowerPoint, I believe.
Yep.
Okay, great. Let's see. Okay, I'm just playing with the settings. Okay, so yeah, if the title is Inpatient Outpatient Transitions of Care, and I will talk about the Owen Clinic experience with these, and Courtney will as well. So when I came up with a title, it reminded me of the Jimi Hendrix experience, and so. I think there is a soundtrack for this talk, and if I think folks are going to be able to hear this. Can you?
Yeah.
All right, excellent. So I'll try not to. It's there in the background. That's Jimi Hendrix blaring for us. So are you experienced? All right. I have Courtney and I have no formal disclosures. Oh, I'm putting the playlist in the chat box there, just in case anyone would like to follow along and for future. After Joel and some of our other outstanding presentations, I thought I really need to step up myself. So at least I can do so musically. So please forgive any glitches, but I think I got this figured out. I may make some unfiltered or provocative statements, and please forgive those as well. So the way this talk is going to go, I have an outline there. So I will start with a brief literature review, sort of the transitions of care literature. And also and then Courtney, I'll hand it over to Courtney to talk about UCSD's program, and what we do here. I'll present a few cases which I think sort of illustrate the type of patients that we see, or a good representative sample anyway of a couple of very interesting cases. And then we recently submitted, we recently did an analysis of a year and a half of our clinic, specifically that we see patients on Wednesday afternoon who are following up on a hospital discharge. So I'll present some of that data. We actually just submitted it to IAS, and I think it'll be a good publication. Then of course there will be time for a discussion at the end. I do have pauses throughout, like in between these sections. So, as people, in case there's anything in the chat box, and if anyone has anything they'd like to contribute, please do, and know that, there will be opportunity throughout. Okay. I think I'm pretty good about leaving time for discussion. So, 8:50, and then, we'll have the music, etc., which are songs featured in and inspired by the talk. Of course, it's Friday, and literally I'm not in love, but we all enjoy Fridays, right? So if I can start with the sort of tour of the literature. A lot of the literature on transitions of care comes from examinations of hospital readmissions. That's a common outcome of interest. Why are we following up people in the hospital? Because we don't want to see them returning to the hospital. And so that's something that we're going to talk about a little later. There's also a fair amount of discussion on adverse events that occur following discharge and how to prevent these, and of course just in general, like what are people's rates of follow-up. So I would say though that there's a pretty sizable knowledge gap in terms of outpatient follow-up among hospitalized patients with HIV, or people who are hospitalized for HIV related illnesses. I think it's important because it's sort of a unique form in our care cascade, in our linkage to care. Often we think about new diagnoses and are they linked to care, and then are they maintained in care, etc. But when someone's coming from a hospital, either as a new diagnosis or sort of patient who's out of care, it's different because we're transitioning from an inpatient setting where we, sort of have a lot of control over, outcomes, et cetera, to an ambulatory setting where we might not. And so I think it is a little unique and a little different than, than a lot of the things we talk about in the routine care cascade. As I mentioned, hospital readmissions is a big focus in the literature, but I'd say that doesn't always tell the full story, especially among special populations such as people living with HIV. Sometimes admissions, are more or less expected, especially in the cases of, severe illness, and or immune reconstitution, right? We know that people might need repeat LPs for cryptomeningitis, or we anticipate a certain portion of complications, where hospitalization is an appropriate outcome. And in contrast, I would argue that sometimes the lack of readmission is sometimes a bad thing, right? It can sort of indicate or portend an overall lack of follow-up. Where are people? We feel like they may need to be coming back more often than they do. So these are just some things to keep in mind as we sort of talk about our experience. The first study I'll mention, this was 2010, and sort of one of the earlier ones that I found in terms of transitions from a hospital. This came from the University of Colorado, and it was a cohort of 65 patients who were admitted to the hospital. They were looking at rates of follow-up and what they called timely follow-up, which was about 49%. It's a small study, retrospective, but, even in this small study, patients who were lacking timely follow-up were 10 times more likely to be readmitted for the same medical condition. I think it was, as small numbers, like I said, 7 versus 1, but still a pretty significant effect. Their hospital stay was also longer, 6 versus 4 days on average. And again, sort of lack of insurance was associated with lower rates of timely follow-up, and that's kind of intuitive. The next study that I'll sort of highlight, this was a larger sample from North Carolina in terms of their Medicaid claims. They were looking at the effect of early hospital follow-up on 30-day readmissions. I didn't write down the number of patients in this, but it was in the thousands. So among patients that followed up with a primary care physician within 14 days, they actually sort of found 2 different categories of patients. For low-risk patients, they had a pretty low readmission rate, probably would have done okay with, let's say a 30-day or even longer period of follow-up. But the high-risk patients, when they were following up, they had a significant reduction in their risk for hospitalization, about 19%. So the conclusion here was that most patients do not meaningfully benefit from early outpatient follow-up, but transitional care resources are therefore best allocated towards really those high-risk patients, and maybe they need even sooner follow-up within 7 days. The last study I'll mention to set this up is that this was from the Mayo Clinic, and here we found no difference in hospital readmissions, and that is sometimes the case, except they noted that patients with an outpatient follow-up appointment were more likely to have an adverse event or readmission within 180 days. So, interesting here again, that might reflect a high-risk population that needed follow-up and therefore is almost more likely to have a readmission or adverse event. So that's a little bit, just to sort of set the table for, what we do at UCSD and why. In summary, the literature is mixed, but in many settings, early hospital follow-up can be associated with a reduction in hospital readmissions, especially for high-risk patients. As I turn it over to Courtney, we have a little David Bowie for you, if I can. All right, we're changing speakers and changing in the transition. So Courtney, take it away. I'm going to be advancing the slides for you.
Perfect. Great. So I am just giving a little rundown about our Transitions of Care program. I'm going to refer to it as TOC, and just how it kind of came to where it is today. So after years of project planning and rollout, 2013 was basically the birth of UCSD's HIV TOC program. Started with our very own Tari Gilbert, who's one of our Owen NPs. As it continued, I started up with the program about 2014. After about a year and a half, we created the actual discharge clinic within Owen Clinic. And about 2 years ago, handed the torch over to Dr. Deiss to be the provider of our discharge clinic. So our overall goal with the TOC program is linkage to care. We're trying to link these inpatients to outpatient HIV care. We're hoping for regular visits, regular attendance to keep them plugged in. We want to make sure that they have access to their ARVs, as well as they're administering them daily once they leave the hospital. We're always up for that U equals U viral suppression. And the thought is, if they have great management over their HIV, then they're probably going to have great management over all of their other comorbidities as well. So it'll be a win-win situation. Some other things we pick up on during our inpatient visits is sometimes folks have a little miscommunication about their ARVs or general knowledge about HIV overall. So we provide that clarification and extra piece of education that they could find beneficial. We're always trying to identify the barriers to care. What keeps them from coming to their doctor's visits? What keeps them from picking up their medication? What prevents them from taking that med every single day? If we can identify it and we can come up with a solution, then we can try to overcome that so that we can jump that obstacle and they can be right where we want them to be. Healthcare system navigation is crazy for all of us, even us that work in healthcare. So we can even just imagine how complicated it is for our patients. And if we're not addressing some other major factors such as mental health or substance use, then plugging them in and the thought of keeping them in care is really an unrealistic expectation. So we have to look at the whole person in general and address everything so that they can be successful in their care in general. When we see patients in-house, we do provide that consistency, and especially with our patients that come in often, it's a tool where we use it to kind of build rapport with them so that they recognize us, we're a familiar face the next time they come in. And then that comfort level will help them to transition into the clinic setting, especially if we swing around and visit with them during their visit, because then it's a familiar face from the hospital. And then overall, just health, public health considerations. If we are managing HIV as well as identifying and treating various STIs, then we're decreasing transmission rates for the population that in our community. So each day we have an auto-populated list that generates for the inpatient side that we review. So this will populate based on the presence of an HIV diagnosis and or ARVs listed on the MAR. Every once in a while, we'll pull in false alerts. So if a patient's on an ARV for Hep B management, or if they're either PrEP or PEP patients, those can be kind of our false alerts for our inpatient list. The Owen inpatient team, we usually get together first thing in the morning and we pre-round. So we're discussing the patient, talking about any labs that have come back overnight, and we're formulating a potential treatment plan going forward. And after we do our pre-rounds, then we get together as a group and we do actual bedside rounds. Now, the bulk of the hospitalized patients are actually non-consult patients. So I work really closely with our TOC pharmacist, Shannon Belcom, and either independently or together, we will then visit those patients as well as chart check just to make sure their ARVs are correct, that they're dosed appropriately. And that's where the next bullet comes in place, our multidisciplinary collaboration. Oftentimes we are reaching out to the primary medicine team, sometimes to the specialty teams for recommendations for, different HIV labs, medication adjustments, whatnot. And sometimes those recommendations, and after we do our review on these charts, they will then lead to formal consults. So then we will pull our remaining team members into the case. Discharge needs, this is a very important piece We stay in contact with the unit social workers and case managers for discharge planning, just to make sure our patients are set up with everything we think they're going to need at time of discharge. Now, this could include any home health services, SNF or skilled nursing facility placements, or DMEs. Healthcare navigation. So this is kind of where we have to work with the patient and kind of play the game of the insurance or jump those red hoops in order to get them into care. Sometimes if they have, for example, a Medi-Cal HMO that our clinic or the clinic of choice does not contract with, then we'll set them up with a visit to their insurance assigned PCP so that they can formally establish care there. And then we'll reach out to that PCP with a request for this referral so that insurance authorization can begin. And resource connection, we're trying to plug patients into any community needs that would benefit them, such as complex HIV case management or financial resources, if their ADAP is due to expire soon, or even if they need bridge funding following their hospital discharge. So at that point, we'll communicate with the case manager and the discharge pharmacy so that they can request charity funding from the hospital, just so we can get them a bridge supply of medications to bridge them over to these renewal appointments. As best as we can, we do try to network and stay in contact with outside HIV clinics and send hospital records out to the clinic providers at time of discharge. Also mentioning what labs are still pending. And again, as best as I can, I try to keep these folks on my to-do list so that I can be following up on these pending labs and then send them over once they're resulted so they can be intervened upon if needed. We also do a sign out for our Wednesday discharge clinic, which we'll get into in a minute. And we do try to do follow-up phone calls, but we really focus on our high-risk population patients, the ones that have a really high chance of readmission or we're really concerned about their medication plan. And then we also do the follow-up calls to these SNFs, because oftentimes we find that they do not have follow-up appointments on their calendars. And we also have found quite a few medication errors when we go through the MAR with these SNFs. A lot of the times related to the lack of administration of high-cost medications such as ARVs. And finally, I help with the Owen OPAT management. So it's typically Dr. Deiss that I'll pair up with, but it is, we follow the Owen clinic patients who are discharged on IV antibiotic therapy, working with the various SNFs or home health agencies for lab collection, monitoring, and any changes that need to be made with lab collection and medication dosing. Next slide. All right, so this is a part of our transitions of care team. We're missing, I believe, 3 or 4 members for our full team, but on the inpatient side, it's typically our nurse practitioner, our inpatient pharmacist, and our attending Owen MD, plus or minus an ID fellow. But we do try to tie in the whole team as needed, just so we can start the outpatient process. And then we do kind of a wraparound communication once they get into the clinic. Next slide. Oh, hello.
Oh, did we lose Robert?
Okay, well.
Right, because he had the slides.
We may have. Let me.
Do you have them, Court, that you can put up?
Yeah, let's see.
There are also, though, this might be a good time to let him come back in and respond to Nettie's comments. Do you want to wait for him to return and then, well, I guess maybe we need Robert for one, but maybe.
Actually, the second one is
a question or a comment.
The second one is for, hi, it's Nettie. The second one is for Courtney because
okay.
first of all, thank you so much for all your great work with transition of care for our patients in San Ysidro. I noted we all were like, oh, Courtney, we remember when you came on. But I'm wondering if you guys are going to talk at all about the transition into the hospital, not just out of the hospital, because we find, I know at UCSD, if they're at UCSD, it's no problem because you guys are all linked, but let's say one of your patients gets admitted to Sharp and you didn't know it and they get worked up for like 1,000 things and then they come back to you and you're like, wish somebody had called me because we could have given them the workup and saved everyone a lot of time. And so I think that front end admission is also an area of needed improvement and communication.
Yes, that actually is a huge barrier, and we really haven't found a great solution for that yet. We still many times will have no idea when our clinic patients are admitted to other hospitals until we either get a call from that patient, or every once in a while one of the case managers from the unit will contact our clinic trying to schedule a follow-up. It's tricky. I do have to say that with the Care Everywhere option in Epic, it has become easier, but I've noticed that it's really hit or miss with Sharp records in particular. Sometimes they pull in, sometimes they don't. But many times it's post-discharge that we're then getting all the information or a portion of the information that we need. So that's pretty hard with the outside ones.
So my apologies. I lost power to the computer.
Oh.
I have no idea. I'm at 50%. So I had, everything just shut down. I think I'm back. Courtney, did you sort of go over our team, I'm sure?
Yes. Yeah.
Okay, wonderful. I'll pick it up here, maybe to talk about the discharge visit.
Yeah.
Courtney, did you finish the answer to Nettie?
Yeah.
Okay.
It's definitely a work in progress.
Okay, good.
It's still definitely a work in progress. So let's see. So these are the most common indications that we've found for scheduling patients in our Wednesday discharge visit. Most of the time, it's because the patients are really complicated. A lot of the times, these folks are out of care for a long time. They've been off their ARVs for months to years. So when they finally come to the hospital, it's because they're so sick they just can't manage at home anymore. So they usually have multiple opportunistic infections at that time. So we try to get them in less than 2 weeks, really, ideally 1 week for follow-up. And that's where the discharge clinic tends to be so handy. For some of the others, usually we'll put them in the discharge clinic if I can't get them in with their PCP in a timely manner, or if they're going to be new to our clinic in general, it's going to take them a little while to get established with a new PCP. So that's where the discharge clinic is a good fit for them. Now talking about the discharge clinic visits. So like I mentioned before, I try to do a warm handoff to all of our TOC players that were on the previous slide. As you notice, Deiss is in red, bold, all caps, because as part of the handoff, I give a general summary of what happened in the hospital, what the treatments interventions were, any pending labs that need to be followed up on. Usually they're back by the time the discharge clinic happens. And also the to-do list that I bullet out is for specific multidisciplinary team members. We have noticed that every once in a while, this to-do list goes missing in Dr. Deiss's view. So in order for it to pop out at him, I tend to put his name in all red, very bold, extra large cap font. So our discharge clinic consists of basically 2 visits. It's our pharmacy or our retro visit, which is so vital for the follow-up. They're going over the medications, they're reviewing the med action plan just for that reinforcement. If patients go out with just that bridge supply of ARVs. They're there helping to gain access for the full supply of medications. We're so lucky to have our retro team. And then the next part is that MD hospital follow-up visit to reassess. And we couldn't do what we do without the involvement of our other team members for all these. I mean, this is just a few of the very important things that they help with: housing, substance use, counseling, plugging them into our MAT program, insurance, OS, and whatnot. So these are the things that kind of help us get our patients to the discharge visit. We do a lot of counseling during the visit and at the time of discharge. Our navigators are calling patients, reminding them about the visit, offering them help with setting up transportation, our insurance barriers that we're addressing. We can be flexible to a point, but the most important, I think, is the anticipation of patient needs. So just getting things ready. If we know that this patient is going to need an IRP hotel voucher, we'll give a heads up to the social worker so that they can start working on that application before the patient even gets to visit. Same with any forms that may need to be filled out, or if patients had a question during their hospital stay that we just didn't know the answer to.
Oh, yeah.
I'll use that time to find out, you know, what we need to know so that we can follow up with them and close the loop during their visit.
Thank you, Courtney. I, was dealing with various things, and so I didn't get a chance to, give you a great introduction. But I think everything that you just shared shows how much you do for the hospital, for the transitions program, for UCSD, and for the Owen Clinic to really, facilitate a smooth, sort of care handoff for patients. So for those who don't know Courtney, it's just tremendous. So we have our clinic on a Wednesday afternoon. And so, skyrockets in flight. Afternoon delight is what I like to call it. All right, so I'd like to go through a few cases, just take a few minutes, before showing some of our data, which is very exciting. So the first sort of illustrative case was a patient who was out of care. She had a history of pulmonary TB. It was unclear if she had completed treatment, also a significant alcohol use disorder, and she came to the ER for symptoms of withdrawal. She was actually consuming 3 liters of tequila daily. That's a personal record, for someone I've known. She was US born, but did have her children living in San Diego, but she was living in Tijuana with her boyfriend. So at the time of the ER visit, she sort of had her withdrawal acutely treated and was discharged. We saw her, Courtney doesn't do a lot of ER visit follow-ups, but maybe when we get one identified that's super high risk, this patient was promptly linked to care. So I saw her, I believe, the next day at the Owen Clinic. The visit was attended by the patient along with her daughter. She had very visible signs of withdrawal. I mean, we just wanted to get her out of there before anything serious. Her medically, other than withdrawal, her review of systems and exam were unremarkable. But her daughter did ask about detoxification programs, and there was some motivation for that. It just didn't seem safe or feasible to do that in the outpatient setting, though. So we referred her back to the ER, for presumed admission. Unfortunately, before she got to the ED, she needed a drink. She was really tremulous in clinic. So, she sort of treated her withdrawal on her own, but then, was calm and no longer tremulous, and then went to the ED and didn't really have a reason to be there, and she left. So the patient and daughter, they came back to the Owen clinic to pick up their medications. It was a real surprise to see her. We just sent her an hour before. Her daughter was quite upset because, the patient didn't look like she was, fully motivated, for care. But later that night on her own, that patient returned to the ED. Their plan was to discharge the patient, but honestly, following a dose of phenobarbital, clinical stability. But really, this was sort of a special case, and Courtney really advocated on her behalf that she'd failed outpatient treatment, and so she helped the team convince her to admit. There was a chest X-ray obtained, really just for placement, but this is what it showed, and you'll see some stuff in the apices. Remember, this patient had a history of pulmonary TB. So unexpected. Diagnosis was a cavitary lesion. She was placed in isolation. AFB smears were positive. Started on RIPE, eventually was hooked up with county operated housing for patients with TB. She did complete several visits at Owen. Unfortunately, it looks like, several months later to a year later, she has been lost to follow-up, but just a tremendous sort of case, and, very unexpected for someone who is at high risk for a poor outcome. The second sort of illustrative patient was a young man with a new diagnosis, admitted to the hospital for severe PJP pneumonia. He also had syphilis and bloody diarrhea, did get better throughout the hospitalization, except he continued to have diarrhea. So there was a colonoscopy obtained, which the initial report said no colitis. So it was kind of unclear, maybe HIV enteropathy. We didn't have a great diagnosis for him. But in that handoff that Courtney described, she found that in the path report, it had been addended to note a rare viral inclusion on the CMV stain. The primary team and the consultants hadn't been notified. This got an I report, because pathology just kind of snuck that result in. They thought they had communicated it, but it hadn't. So in any event, the patient was doing a lot better, but he was still having a lot of diarrhea. At the visit, we gave him valganciclovir, obviously, and his symptoms resolved. This has been a good success. He remains in care at 9 months and is virologically suppressed. Just a brief
Robert, was
note.
that a UCSD hospitalization or an outside
Yes,
hospital?
UCSD.
Okay, so even the whole internal hospitalization doesn't always work either.
Doesn't always, right? Exactly. Like I said, this got a sort of an internal quality improvement report, and then there was a case just like it where like a week later, almost the same thing, and PATH called, like they sent a telegram essentially to the patient and notified. So it was, it's funny how those things work. Just again, a quick reminder, like test pending at discharge, right? These are things that, pop up in our consciousness. The last patient, this was more of the routine visit, quote unquote. This was a patient who had stage 5 CKD and hypertension. He was following up on a recent admission for volume overload. He just had a PD catheter placed 2 days prior as an outpatient. But at his visit, he just didn't look well. He was complaining of abdominal pain, generalized weakness, using a cane for ambulation, which is atypical. And on exam, he had a blood pressure of 220/132 and diffuse abdominal tenderness. So he was referred to the emergency department for further evaluation and treatment. And then 1 hour after arrival, was found to be unresponsive with a facial droop, had a hemorrhagic stroke, and he was actually hospitalized for 1 month and then later at a long-term care facility. Now he's doing well, sort of slowly recovering his neurologic function, but this was obviously a coincidence that he happened to be on our clinic on that day that he was going to have a significant event and stroke. You can't imagine a better place to be, perhaps, than an ER on a monitored bed when this happens. So he was able to get prompt care, and the discharge visit was wound up being sort of critical. I can't say that's happened again, but it's a pretty nice illustrative case for that. So the Owen Clinic, we can be heroes. just for one day, right? This is the final section of the talk that I will be doing, and that's to talk about sort of, you know, some of our data and some of our outcomes. And so, yeah, like I said, I think there will be some time to discuss at the end. So what we did, we looked at the discharge visits that had been scheduled between June of last year and when we started the program, and November 21 of this year, and that was about 114 patients. Many of them had, you know, multiple admissions, and so we only counted their first to see, you know, how good they'd be about attending that initial visit. Our outcomes of interest, we did a logistic regression to identify, did they show up to that visit? Did they show up to any visit within the 30 days? For example, if they missed that initial appointment, were we able to get them back into clinic? Because that's something the transitions of care team sort of does as well, until that patient is really tucked in and has stable follow-up. Last, we looked at readmission, sort of, you know, because again, that seems to be always be one of the outcomes of interest when you're talking about hospital follow-up. There was sort of on the patient level, some of the important factors that we included in the model and examined were, you know, was this patient receiving IV antibiotics? Because those patients are going to show up, right? They have PICC lines, you know, and, you know, they have stable situations at home, and they're going to be, you know, needing to come back to clinic. Are they at a skilled nursing facility or incarcerated, right? Because again, Courtney mentioned, you know, coordinating transport with them. But again, those, when we have a patient going to one of those facilities, we kind of know they're pretty likely to come back to that appointment. You know, we looked at, was a patient newly diagnosed within the previous 30 days, you know, not necessarily during the hospitalization, but again, that's sort of a unique group in terms of linkage to care. And then some, you know, psychosocial barriers. Did they have a substance abuse disorder, mental health disorder, unstable housing? We looked at Courtney's notes to see if they were identified with a health insurance barrier, and of course some, you know, HIV related characteristics. So our overall show rate at that initial discharge clinic appointment was, you know, not, you know, pretty, this was better than I expected maybe, but about 70%. So that 30% no-show rate, that's, you know, not too far off from our clinic rate, which is about 20%. And this is a very high risk population, as we've sort of pointed out, and even better, you know, as far as people attending any appointment within 30 days, you know, we got 11 patients rescheduled, so about 80%, you know, had that important early follow-up. All our patients with a new diagnosis were linked to care, 10 out of 10. And we had about a hospital readmission rate of about 19% within, you know, 45 days. You know, in terms of urban sort of hospitals with a high risk population, this isn't too far off. And so, you know, that's sort of what it is. So let me show you a couple things about the population. I want to first, you know, just general demographics, sort of mirror our clinic in terms of our median age and, you know, female sex assigned at birth, et cetera. And, you know, I'll sort of come back to this. There's a reason I'm pointing it out. But about, you know, 30%, almost a little more than a fourth, identified with of patients identified with Hispanic ethnicity. Not many are suppression rates, as expected in a sick hospitalized population, were, you know, not that great, around 40%. But fortunately, you know, the CD4 is averaging, you know, somewhere in the 200s. So it's a sick population, and especially, I want to really show, these are some of the psychosocial issues. High proportion of patients with the substance abuse disorder, almost half. Again, 40% with homelessness or unstable housing, a lot of mental health disorders. And if you look at, this was sort of a couple composite variables, at least 80% had one of the above, right? So had some sort of, you know, psychosocial challenge in terms of their overall care. 30% had all of those, right? And then a sprinkling of patients on OPAT or new diagnoses. So the first sort of outcome we looked at was factors associated with that hospital visit. Did they attend clinic? And as you see sort of in the bold, patients with a substance abuse disorder were at risk for not completing that visit, homeless patients as well. And again, if they had that trifecta of all three, they were significantly at risk not for a no-show visit. In terms of, that was the 30-day data, I believe, right? Any hospital follow-up within 30 days, right? So it wasn't very, when we looked at the initial discharge visit, these were very similar factors throughout. I'll have a summary slide as well. So this was our readmission data. Again, I mentioned the overall rate was about 19%. And here, this was interesting. The factors sort of that were important in terms of predicting a hospital readmission were again, that trifecta for people who had at least a substance abuse disorder, psychiatric disease, or mental health disorder, and homelessness. And actually, ironically enough, did they have an insurance barrier? But that was a little unexpected in terms of the outcome. If they had an insurance barrier, they were unlikely to be readmitted. Whereas if they had a barrier, they were, I'm sorry, if they had no barrier, they were often readmitted. If they had a barrier, they did not get readmitted. This was a little unexpected. What we think is going on is that obviously patients could then be going to other healthcare systems and, not showing up to our clinic where they might be in care and then having, sort of additional testing procedures at a hospital itself. We did not, that hospital visit, either the initial or 30-day follow-up, were not associated with readmissions. I think Nettie made a comment earlier that, we get dinged on readmissions and needing an early and prompt, primary care appointment. And it's not always clear that appointment prevents readmission. It's still very important in terms of people keeping patients re-engaged in care. I would say that's not the number one outcome we need to be looking at is readmissions. So again, just in summary, what we found, in our discharge clinic, the lack of a substance abuse disorder sort of was predictive of, attending that initial visit. Again, that trifecta of substance abuse and a mental health disorder and unstable housing was a high risk for no-show. And actually patients with Hispanic ethnicity made those visits. It's a huge confidence interval. We didn't have a whole number of patients, but many of them were in that new diagnosis category. And that was a group that, as I mentioned, sort of really had a good positive show rate. Again, what was the risks for readmission were that trifecta of a substance abuse, a mental health disorder, and unstable housing. As I said, that insurance barrier sort of was a little unexpected in terms of being good for lack of readmissions. But again, I think patients are just sort of seeking care elsewhere at that point. So, just to summarize the overall talk, I think we found relatively high rates of hospital follow-up, even among a population with significant psychosocial challenges. Again, really 80% of people having either a substance abuse, mental health disorder, or unstable housing. Nonetheless, there are significant challenges in re-engaging patients with some of those barriers, especially substance abuse disorders and unstable housing. And these barriers are often additive and multifactorial, right? We did see success in our sort of group with patients of Hispanic ethnicity, the newly diagnosed, and if they were coming from a facility as well. So where do we go from here? I think, next steps, we want to, in this analysis, we're going to look at our retention and care data at 6 months. It was a little early to do that. We want to see if how well patients are doing.
Hey, get off of my...
how well patients are doing in follow-up. It would be nice to do sort of a cost effectiveness analysis. I think this clinic, those 3 cases I presented, really sort of, prevented, really poor outcomes. And so, this is always a thing that we deal with in HIV care and ID, is preventing illness and how do sort of systems capture that. It would be great to improve inpatient treatment for substance abuse disorders, link them to our clinic for medication assisted treatment. I know Dr. Bamford and Raj Kapal are really working on this to sort of improve the in-hospital, treatment of substance abuse disorders. It would be ideas welcome to address homelessness and unstable housing. It's a huge issue for us. I thought I'd show you some sunrises from this morning. It was very, very nice and beautiful. And then acknowledgements. I'd like to thank Afsana. Oh yeah, there's a song for this one too. And that's Dido thanking us. And for giving me the best data of my life is what I wanted to say. Lucas did a lot of the analysis, and so thank you for that, Lucas. He reminds me that it's not so bad. It's not so bad. The transitions of care team, not all were photographed, but obviously do this work tremendously. And I would like to say to them that nobody does it better. Okay, I think we'll end with that. We'll have time for discussion, talking about a revolution maybe, but I'll let Carly Simon fade us out. So that's all I have, I think, yeah.
Robert, I don't even know where to begin. That was incredible. You may be competing with Joel Wertheim.
I don't think but again, that playlist is available. I'll put it in the chat box again.
Yeah, someone actually just asked again, can we get mixtapes of the soundtrack? So
Yeah.
not, could you actually make the tapes? There are a couple of good questions that we should go back to. Nettie, I think your first question was answered about the quality measures. I hope so, and that was a while ago, but let me get to the other ones, and if you feel like it wasn't, we can bring it back. Sorry. Okay, so I think Darcy had a very good question with the Hispanic ethnicity, whether the barrier changes. Does this have to do with monolingual or bilingual speaking patients? Did you look at that with those with the Hispanic ethnicity?
Yeah, good question. I don't think we did. I think that data is available. The EPIC data isn't great when they capture, monolingual, bilingual. I don't know if Courtney has any sort of anecdotal observations. I know that they've tended to be more monolingual Spanish, or at least Spanish preference. And that's sort of similar with, prior experience I've had in other institutions that sort of have a good follow-up rate sometimes for those patients. A lot of them were in the new diagnosis category, I would add, and sort of that group did overall pretty well.
Yeah.
So yeah, thank you, Darcy. It's a good idea and something we can look at.
Yeah, I don't know. Just thinking back about the patients that we collected the data on, I don't think we had too many that were just monolingual Spanish. I just thinking back from past experience, even with the monolingual Spanish, if they have a family member or supportive person within their support system, they tend to actually make it to their visits. Just thinking back, I almost feel like it was more the bilingual patients who ended up coming back to the ER or for readmission. Yeah, because usually with the monolingual, they often have a family member with them. Not always, but that also helps to keep them motivated to engage in care.
So Shannon put an article in the chat, and that's I'm sorry. Did that? I think we maybe covered that one.
We did.
Shannon, thank you for that. I didn't find that in my search, for this talk. So, there was a sort of 30-day readmission rate, with about 13% at a separate institution. We, at multi-center study. So, we did 45 days, just because when we looked at 30, it was just, it wasn't enough, and B, like a lot of admissions happen on day 35, so I think we tried to capture a little bit more. It was somewhat arbitrary, and that's happens a lot in the literature. So, yeah.
Well, I think what's interesting about that study, it's almost 10 years old, and it's about the exact same readmission rate that we're seeing for the HIV patients compared to the general population. So it's like, that's maybe discouraging or maybe encouraging. I don't know, depending on how you look at it, in terms of, well, we're not getting any worse, but are there particular things in our population that we can start targeting? Like you said, the substance use disorders and the things that are not moving the mark on that, that are biggest barriers.
Yeah, no, I mean, I think this is one of these things that, you see the number, and the number is the number, but boy, it could probably be a lot worse, right? Without all these sort of efforts and resources, imagine. So, yeah.
There's a
question from Alan McCutcheon, which maybe he wrote a few extra words. I'm trying to figure out how often do you have or need to communicate with patients after discharge by phone or text, or have the means to communicate with them? I'm not sure, Alan, if you want to unmute what you were asking, but I'm sure you can address both, Courtney and
let me just say, I wasn't clear how often these people had smartphones or phone numbers or other ways to reach them, and whether we had any kind of reminder programs, about their visits and that sort of thing.
Yeah, so a lot of folks actually do have smartphones. I think those Obama phones tend to be smartphones. And that's part of our standard set of questions during the inpatient side, is confirming or verifying their phone number, because oftentimes the phone number we have listed is now invalid, or they have a new phone. So I would say probably 90% of the time they will have a phone. If we're very suspicious, I will call their phone from the bedside phone to make sure it's truly their phone number. And usually we only do one follow-up call afterwards. It depends. If they're a high-risk patient, either Shannon or myself will do a hospital follow-up call, and then they will receive a second reminder call by one of our patient navigators, typically Carla. And then at that follow-up call, the second one, she'll address the need for any transportation or barrier access to come to their clinic visit. Recently, we did find out that we can use Doximity to text. So that will be also a backup plan if they do not answer their phone, but then you can't really know for sure if they read the text or, put the appointment in their calendar. So we always prefer to speak with them on the line.
Can I add that, those phones also, unfortunately, sadly get stolen a lot. We see that in our clinic. And so, it's yet another difficulty that we see.
There's another question, and you have a minute, so you may want to go through fast. Dave asks, to what extent are you systematically screening for mental health, substance use disorder, housing instability for patients, and obtaining psych consults? Yeah,
that's at least for the substance use mental health. That's all part of Courtney's in-hospital assessment. So everyone is screened. Psych consults are hit and miss. Sometimes there's just not an acute need for them, but sort of a background of a mental health disorder. So yeah.
So typically the inpatient social worker will also get involved, especially when it's substance use related and housing. But if it's a case by case scenario, but sometimes if a patient's really motivated and they're displaying actions to show that they really want to enter a residential treatment, and even they don't even have to do all of that, but we tend to then link in Vernay, our substance use counselor, to link up with that patient, start talking about readiness. And she is such an asset for our team because then she can help kind of facilitate that entry into a program. And sometimes it can actually happen right at discharge, that they will discharge to a treatment facility. Psychiatric consults for the inpatient side. We do get a lot of walls put up by the primary team if there is no acute need. So typically we have to, if there's no real acute need, we usually have to make a pretty good case to get psych involved.
All right. Jill, I think that's it. I have maybe one final musical cue. We gotta run. Right.
Well,
right.
Thank you for the entertainment and really thoughtful presentation, great discussion. I think it'll be great to keep collecting this data over time and have more to share with the group next year. See your accolades.
Yeah,
and
thank
praise
you.
in the chat.
Yeah, appreciate it. Thank you. Thank you all. Thank you.
Thank you.
Even to Darcy, who sort of helped set me up with this last year. Yeah. All right.
All right.
Bye,
See
everyone.
everyone next week.
Bye.
Have a good weekend.